Good afternoon, everybody, and welcome to our first webinar of our 2018-19 year. We're very pleased to have Dr. Wein with us. Today, we're going to be focusing on spasticity, which is a significant issue for many of our patients post-stroke. Just judging by the number of people who have registered, today's webinar is a record number of registrations for all of our Stroke Best Practice webinars, really defines how important this topic is and how interested people are in learning about it. And it will be an awesome presentation today. So I'd like to introduce our speaker, Dr. Ted Wein. Dr. Wein is an assistant professor of neurology and neurosurgery at McGill University, and he works at, also works at the Stroke Prevention Clinic, and he is a William Osler Fellow. Dr. Wein completed his neurology training at Montreal Neurological and his cardiovascular fellowships at the University of Texas in Houston. We've been very fortunate over the last several years to have Dr. Wein as our co-chair for the Stroke Best Practice Prevention module, but his research interests are also very much in recovery and rehabilitation, and spasticity is a particular interest and specialty area of his, so we're very fortunate to have Dr. Wein. So we'd also at this time like to encourage you to please ask your questions, write them in on the panel as Lisa indicated, and at the end of Dr. Wein's presentation, we will be reading out those questions and Dr. Wein will respond for us. And as Lisa mentioned, please do an evaluation afterwards. It's very important to get your feedback and to let us know what other topics you're interested in so that we can continue to provide you with education that meets your learning needs. So with that, without further delay, we'll introduce you to Dr. Wein and turn it over to him. Thank you, Ted.
Thank you very much, Patty. I'm just going to set this up here. So thank you very much, everybody, and thank you for taking the time to attend this presentation. And thank you so much to the Heart and Stroke Foundation to really give us an avenue to talk about a really important and critical aspect of stroke care that I personally feel is really neglected. I'd also like to acknowledge Patty Lindsay, who's been an instrumental force in us having these Canadian Stroke Best Practice guidelines, which are recognized around the world and have really put Canada at the forefront in guideline development. So thank you, Patty. I would like to disclose the following. I have the following grants and research support. I've been on a speaker bureau, and I'm a consultant for 2 of the 3 Botox or neurotoxin companies that are on the market and do have some indirect relationship with them. I don't have shares or stocks in any of them, but we are going to be talking about spasticity, of which neurotoxin is one of the therapies. These are all my own personal slides, and there's nothing else to divulge here. This program was created independently of any pharmaceutical company interest or influence. And I've had complete control of all of these slides and their topic that I wish to discuss with you. And my objectives for today are several-fold. One is to talk about identifying spasticity in the stroke population and really looking at does stroke occur in the acute stroke setting. 2 is going to be, once we do look for stroke in the acute setting, are we actually recognizing it? Are we treating it? What do the guidelines tell us? And when do the guidelines tell us that we should be initiating treatment in this population? And the last question is, for the most part, as you'll see shortly, the guidelines suggest that we should treat spasticity late on, or at least most of the data supports using treatments later on in spasticity. But we don't really have a lot of guidance on what we should do with early detection and early treatment of spasticity, predominantly with chemodenervation, which has become the mainstay of therapy. There are lots of other treatments for spasticity that I fully recognize, and I think everything should be treated in an interdisciplinary, multidisciplinary, poly approach. But the question is, do we really do that? At least my institution, very few acute stroke neurologists have an interest in spasticity. It's really not a practice parameter performance measure that I really think it is. And I hope with today's presentation, which is really to look at does spasticity occur in the acute onset. I'm not going to give you a lot of treatment tips, but I really want to focus on treatment. And if we can treat early, will that modify how severe spasticity is down the road when we tend to be more aggressive at treating it? So before we talk about treatment and identification, it's always important to talk about what the definition is. And this has been a big bone of contention because we have very different approaches to what people call spasticity. And what the original definition is what we currently use the term so loosely as and what some more modern definitions are really quite different. And the question is, are we always treating the same entity, or are we treating a variation of the same process at different time points during its development? So in the 1980s, Lance described it as a motor disorder characterized by a velocity-dependent increase in tonic stretch reflex with exaggerated tendon jerks resulting from hyperexcitability of the stretch reflex as one component of the upper motor neuron syndrome. Now that's a mouthful to say, and I'm still not sure I fully understand it, but basically what Lance was describing was he felt that spasticity was associated with an increased change in tone that was always direction and velocity dependent and had to be associated with increased reflexes, such as increased ankle jerks, for example, or clonus. And that's not always the case what we see, and I find we use the term very loosely. And in doing so, we usually talk about people who have changes in tone. Does it really have to have hyperreflexia at the beginning? Is hyperreflexia an end process or an early process? And I think it's important to note, because when we do our research trials, I'm not really sure who people are putting into these trials and if they're following this initial definition. A more recent definition was Pandayan and colleagues in 2005, and they tried to redefine spasticity to deal exactly with that precise issue. They described it more as a disorder of sensory motor control. So looking that there is some sensory influence into this, resulting from an upper motor neuron lesion, presenting as intermittent or sustained involuntary activation of muscle, focusing on positive features, such as increased levels of involuntary motor activity. So again, stressing that there's a change in tone there, while excluding negative features, which would be reduced muscle tone. Of a syndrome and the biomechanical alterations in its joints and soft tissues. And by doing this, they try to open up the field a little bit more to say, if we're going to use the pure definition of spasticity, that really doesn't capture everybody with an upper motor neuron lesion who will have changes in tone. There's clearly some sensory motor influence into this, and we see that how people with nociceptive influences, we see their tone changes, and that they also recognize that will be changes in joints as well as soft tissues, as all are other things that will need to be addressed when we talk about spasticity. In all, I'm pointing this out because when we do a research trial, we have to have as much of a pure population as we can. And I think many of the failures of many research trials on spasticity research are because we're including a variety of people on different spectrums of this process. This is a wonderful cartoon developed by a dear colleague, Georg Wissel, who now resides in Berlin. And it really goes to discuss what's going on. If you have a spastic paraparesis, we usually initially have some CNS damage, which leads to paresis as a direct result, which then leads to immobilization and short positioning. And then it causes soft tissue plastic rearrangements. And as we have disuse, things sort of change. In the cortical level, we have cortical plasticity and rearrangements, both at the supraspinal level as well as the spinal level, and that tends to lead towards muscle overactivity. And when we talk about muscle-like overactivity, we go back to what this basic definition of spasticity is. Is it the classic definition of spasticity? We see so many people who walk and their arms go into flexion or their toes will curl, and we'd call that more of a spastic dystonia. And then we see individuals who try to initiate movement and get spastic co-contraction. And the question is, are all of these patients the same or not? And I would argue that they're the same evolutionary basis and same spectrum of the same disorder. However, they seem to respond somewhat differently to various therapies, with the spastic dystonia as being the most difficult to treat. Most interesting is, why are we doing this? Spasticity is the biggest predictor we have of long-term disability in our stroke patients. And as far as I'm concerned, we should be incredibly aggressive of trying to treat that, because we always look for the end result of spasticity, which is contracture. And if contracture sets in, as far as I'm concerned, we've lost the battle in terms of trying to save this person's maximal functionality as well as quality of life. So I do not think we should be waiting for contracture to set in, because to me, that's the end process of this dynamic process you see above. But we should really be trying to intervene earlier on in order to try to prevent contracture from occurring. And that's one of our major treatments for spasticity, is really the prevention of contracture, since we have not been very successful in trying to demonstrate functional benefits in these people. So while I pointed out to you that spasticity is the biggest predictor of a bad outcome in people, it's really not the sexiest topic in the world. And last night, I actually did another PubMed search on this. And if we look at post-stroke spasticity, there's only 532 articles that have been written on this. There were 490 at the end of 2017. So we're not exactly moving ahead or forward by leaps and bounds in this field, despite the fact that every article states that this is the biggest predictor of disability and poor quality of life. If we look at nursing care, we have almost 6,400 citations, dysphagia, almost 2,000 citations, and post-stroke rehabilitation, almost 5,800 citations. So while we keep on claiming that this is a terrible complication of stroke and a poor predictor of outcome in our patients, we don't seem to be devoting a lot of time and energy to research what should or should not be done for these patients. Post-stroke spasticity is consistently demonstrated to have a negative impact on patients' quality of life. And let's face it, outside of the acute stroke setting with thrombolysis or thrombectomy and stroke unit care, this is really what we should be focusing on. Who develops spasticity? What can we do to prevent it from happening? Can we identify who will get it? And does early intervention change that? If you have post-stroke spasticity, you have increased number of falls, you're at higher risk for fractures, higher risk for pain syndromes, and most importantly, it's an increased caregiver burden and a huge cost to the healthcare system. In individuals who have spasticity, their stroke care costs are quadrupled when compared to stroke survivors without it. This has a huge financial and economic impact on us, has a huge impact on the caregiver burden, and that is why we should be paying more attention to it. If we look at our Canadian stroke best practice guidelines in section 5.2, you can see what we write here. It says that spasticity and contractures may be prevented or treated by antispastic pattern positioning, range of motion, exercise, and stretching. And we look at it as interventions in the early stage where we only give it level C, and in the late levels where we also give it level C. We can write that routine use of splints is not recommended in the literature, early level A, late level B. However, certain conditions or scenarios do permit their use. In some select patients, the use of splints may be considered, but all of this is level C evidence. But if we go down to point 3 with the red arrow, you can clearly see that chemodenervation using botulinum toxin can be used to increase range of motion and decrease pain for patients with focal and or symptomatically distressing spasticity. But we give it an early level C indication because we don't really study it early on. And we give it a late level A because the majority of patients that are enrolled in clinical trials are late on in the process. And the question is, why are we waiting till people are significantly disabled prior to intervening in this patient population? We have several other medications, and I'm not saying botulinum toxin is the only therapy. We have oral medications such as tizanidine and Xanaflex, which gives you an early level C and late level B, has the side effect of sedation. We have baclofen, which was my first job when I was on the rehab guidelines, was to try to find a randomized article for baclofen use for stroke care, and they're really not there. And then benzodiazepines may be used, but we try to not use them due to sedation. But if you look at all of these recommendations, early evidence level is always C, and most of the patients we treat are later on. Is this because spasticity doesn't occur in the acute setting, or have we just not made the effort to initiate therapy at that point in the hopes that patients may get better? If we look at both European and American guidelines, they don't even talk about therapies. They look at, in the red box below, treatment of upper limb and lower limb spasticity. They recommend to use any of the botulinum toxins. They give it guideline evidence A, but if you looked at the interval of when it should be treated, they're saying it should be done after 12 weeks or after 3 months of care. Why are we waiting so long for people to be treated at that point? Is there a logic and rationale for that? And are patients paying the price? More importantly, if we intervene early, can we modify spasticity to decrease the development of contracture and to help improve social integration, participation in rehabilitation, and perhaps decrease caregiver burden and decrease pain along the road? So this is a webinar, and I foolishly made this sign saying, let me see your show of hands. So if you can just humor me and actually raise your hands, but how many of you in your institutions, predominantly in the acute care facilities, actually have a protocol for treating and identifying spasticity in the acute phase of stroke, in that initial phase in the stroke unit? Is development of spasticity a practice parameter at your institution? How many of you, on the other hand, when patients discharge either from rehab or from your stroke unit, actually have a long-term protocol on how to follow these people? Do you identify who's potentially at risk for spasticity? And do you have a means of watching these people and following them in order to assure they receive proper follow-up? And I think if you don't, these are all things that really should be discussed with you. And then the last question is how long should we follow patients for the development of spasticity? Is there a time window that it occurs and after which you don't have to worry about it? Does it happen in the early setting? Does it happen after 3 months? Because that seems to be when most of the trials and guidelines suggest we evaluate it. So early identification, why should we do it? Early identification of high-risk patients and early diagnosis of post-stroke spasticity are really essential for optimizing patient care. Patients with disabling spasticity have worse Rankin scales and they have a worse Barthel index. They are functionally disabled. Multidisciplinary, and this is from the article, but really interdisciplinary teams should learn to better recognize this, as the early signs of post-stroke spasticity should be intervened to help prevent progression and hopefully will enhance patient management as well as intervention. So what will happen with early diagnosis and treatment plans? Well, we can reduce the risk of secondary maladaptation or help them integrate better into their rehab setting. We can try to reduce overall impairment and improve workplace performance early on, not tell them they can't work anymore and then try to treat their spasticity. Try to increase social participation or social reintegration, and most importantly, try to improve their long-term outcomes. So how can we do this and why should we do this? And I guess the next question is, since we're traditionally treating, at least with chemodenervation, people later on, how many of you believe that early treatment of spasticity improves long-term outcomes? Do you think if we were more aggressive in the acute phase of this disease, and when we first see those changes in tone at the wrist, elbow, or equinovarus foot deformity, that we can actually influence long-term outcome? Do you think that would change things? And the second question is, do you think if we initiate therapy on somebody early on in the acute phase, or initiate somebody greater than 2 years after the stroke, that we actually get the same response to our treatments to these patients? Or are we putting people at a disadvantage in order to try to secure the best possible outcome for them? So the major question is, does early treatment actually influence long-term outcome? So let's go through the following articles. And I'm just trying to belabor a point here. But if we look at these articles, in the Lundstrom article, the first box here, they found spasticity in around 4% of their patients between days 2 and 10, and disabling spasticity around 1 month and around 2%. So a small percentage of patients that they found in that study. If we look at the next two articles, however, Summerford and Wissel, looking at anybody with spasticity, they report spasticity in almost 1 in 5 patients. And in Wissel's study in 2010, 1 in 4 patients actually had some form of spasticity at 2 weeks, and 10% of them were found to have severe spasticity with a modified Ashworth of greater 3 in that 2-week period. So still 1 in 10 patients may have severe spasticity, and 1 in 4 to 1 in 5 patients actually, while they're in that stroke unit and transitioning to that rehab hospital in those first weeks, will show that they have significant spasticity. If we look at the paper just below it with no box, so that's the study by Peter Urban, severe spasticity is seen in almost 16% of people in that acute phase. More interestingly is this article by Opheim and colleagues, where they found spasticity in need of treatment at 3 days in 1 in 4 patients, in 24 patients. And at least in their center, some 43% of patients had significant spasticity at day 10. So still very concerning that this really does occur in all of these different trials, and they're all European trials. So we're looking at a European population with a bias towards the larger academic centers. But as we move more and more to designated stroke hospitals in this country, we should be seeing the same thing. And 1 in 10 to 1 in 5 people having spasticity is really an important marker here to see what we can do to help improve their long-term outcome. When they looked in these articles, they tried to figure out who's at risk for having significant post-stroke spasticity. Paresis, by definition, is the biggest risk factor, but that's kind of dumb because this is a stroke trial and people are going to be paralyzed. If you had a modified Ashworth scale of greater than 2 in more than one joint at 6 weeks, that was a predictor. If If you had two joints affected by a change in tone, those people were more likely to develop significant post-stroke spasticity. Individuals who had both involvement of upper and lower extremity at week 6 seemed to be really at risk. People with low Barthel indexes or these bad strokes seemed to do worse, and individuals with more severe paresis also were at risk. I find these predictors a little bit dumb because they're basically saying if you have a bad stroke and are weak and are significantly spastic, you'll be spastic down the road. But at least it implies one thing, is that A, you do see spasticity less than the traditional 3-month period, and more importantly, we should probably be doing something about it because it predicts poor outcome. We've looked at a lot of different other potential risk factors, but the thing that comes out all the time is severe, big bad strokes have more tone, and after that, there's some sensory motor things that may influence it well. And we're going to look at this from a different perspective. One of the reasons why people have shied away from being a little bit more aggressive with treatment early on is from this study by Jörg Wissel that looked at the evolution of spasticity over a 16-week period. And while at baseline, in his small study, it's only 23 patients, were found to have spasticity, if we look at their first follow-up several weeks later, you can see that, if you look at spasticity here, you can see from these 23 with original increase in tone, initial muscle hypertonia, you can see that some of them actually lost their tone, but we also see that new patients develop tone. And if we look at the evolution at their second follow-up at around 16 weeks, in this small study, around a third of patients actually had decreased tone from their initial increased tone. So the concern has always been, is this a permanent fixture that will be there, or do we think that other people will develop it, or that we may treat someone that will resolve and worsen their function? And to date, that has never really happened. The Salgut study was an interesting study done to look at the evolution of spasticity as well as a predictor for spasticity. I believe in Denmark the study was done, and basically looked at outcome at 12 months for any spasticity, and they also wanted to look at what the outcome was of their patients at 12 months for severe spasticity, because those are the patients we really want to try to identify. They looked at age, sex, smoking, stroke severity, stroke side. They had an NIH stroke scale arm as well, and then they used the Fugl-Meyer assessment scale, which I do not personally use at our institution, as well as range of motion and sensation, to try to figure out, can they predict who or who will not develop spasticity? This slide is a little bit difficult to understand, but basically this is the prediction of, I'm sorry, my slides are jumping. They were looking at what the risk of developing spasticity is. And in fact, we see here that individuals with really bad Fugl-Meyer scales, predominantly sensory motor changes on their Fugl-Meyer scale, help predict spasticity down the road. In fact, developing permanent spasticity of any type was best predicted at week 4. But most importantly, severe disabling spasticity was predicted by a poor Fugl-Meyer scale at day 10. So we do have at least one scale that's not used very often, but the Fugl-Meyer assessment upper extremity scale at day 10 was the best predictor for severe spasticity down the road. We should probably be making a little bit note of this on this small study published in 2015 to say, hey, maybe we are able to predict who is going to develop bad spasticity and perhaps be a little bit more aggressive in watching those patients. This is a study I did with my colleague Brett Casella and Tom Brott and Joe Broderick at the University of Cincinnati. It's part of the Greater Cincinnati, Northern Kentucky Stroke Study. And we were trying to find some North American data to establish what the prevalence and incidence of spasticity is in our population. And very interestingly, we looked at 1 year of patients. I believe it was in 2013 that we did this. And we looked at everybody from baseline at the University of Cincinnati stroke healthcare system. So regular physiotherapists that are involved in spasticity treatment. And we looked at the labeling of spasticity at 3 months, which was around 22% of people, which is very similar to the prevalence rate we saw in the European stuff. If we look at 12 months, however, we can see that the rate of spasticity is around 18%, so still relatively similar. Some people will pass away. But what's most interesting in this study is that there was a new development or a new diagnosis of spasticity in around 11% of patients, suggesting that we do see spasticity early on, but we also see spasticity developing after that 3-month initial visit, and sometime between 3 months and 12 months, we should probably be following these patients to ensure that they're not developing spasticity at that time point. We also tried to establish whether there are any risk factors for stroke, for post-stroke spasticity, besides having a younger age, as well as being African American. We didn't really find anything. People tend to be not employed and on disability if they had spasticity. Otherwise, we didn't find any other good predictors except for TI, hypertension, and coronary artery disease, which were all pretty vague. Perhaps the coronary artery disease may have bigger strokes. TIA is not sure how that influences it, but we really don't have any other great markers outside of the Fugl-Meyer assessment scale early on to suggest who will develop significant spasticity. So let's go to the next concept here. And so we can see now that spasticity does happen in the acute stroke unit, does happen in the first 2 weeks. We know that at 10 days, that may be a predictor for severe spasticity at 1 year using the Fugl-Meyer assessment scale, and that sensory motor influences seem to have some impact in it. And so what happened in 2010 or 2009 is Elizabeth Cousins and Tony Ward at Stoke-on-Trent University in the UK had a very interesting idea. What would happen if we gave botulinum toxin to individuals early on in their stroke? And what they did is they looked at individuals within 3 weeks of their stroke who had severe arm deficits. And what they did is they said, let's inject low doses of botulinum toxin into their finger flexors, their wrist flexors, and see what happens. And what will happen if we follow these patients up to 20 weeks? Will we modify the severity of their spasticity, and will less people have contracture, and will less people have other complications commonly associated with spasticity? And so what did they find? They found that individuals who had no recovery of arm function, so they found in the subgroup of individuals that had 0 on 5 MRC strength in their arm, that they did actually show some changes in tone and had less contracture than those that did not. And so when they injected to the people who were severely paretic but still had some function, they didn't see any significant change. Although I'd point out this is a very small study of some 20 patients, so 10 patients in each group, not making great generalizations, but they were able to demonstrate that individuals completely paretic, those bad strokes, sort of what one of the risk predictors are for significant post-stroke spasticity, actually did better than those who weren't treated early on with a low dose toxin that we don't usually do. So that was just one study, and it was a proof of concept. And I want to go through several other studies that are looking at the exact same thing. This is from Hess and the Berlin group, where they also decided to inject individuals in their finger flexors early on with botulinum toxin to see if that in any way might affect how patients evolve over the next 6 months. Their definition of acute, however, is not in the acute stroke setting. It was really patients within 4 to 6 weeks of their initial event to see if that would change anything for them. And they found that early Botox, botulinum toxin injections in severely affected stroke patients actually did decrease tone some 6 months later. Again, they found that in individuals who were completely plegic, they seemed to have the best response to the therapy. And they also found some decreased contracture development, suggesting that early intervention may be beneficial. Again, I don't want you to take away a message that this is standard therapy. This is all proof of concept, and these are all very small studies. But I want to show you how many little small studies are out there and what they all say. In 2012, Ray Rosales from the Philippines actually had this study called the Abcdes Trial. And what they wanted to do was look at individuals also early on with their stroke who had MRC scores of less than 2 and inject them also with low-dose toxin into their finger flexors to see if they would have any change in their modified Ashworth scale, develop contracture, but they only looked at the patients up to around 24 weeks. And so to be eligible for this study, you had to have a modified Ashworth of 1+ or greater, so just only mild tone. They did find in the study that you were able to improve the modified Ashworth scale, and I'll show you that shortly. They found no change in function at 4 weeks, but I would argue pain needs more time than 4 weeks to change. And the Barthel index and MRS scale, at least in that short time period, didn't change. But most importantly, there was decreased tone that had evolved in these patients as they were only followed out to 24 weeks. And probably if we were to do a good study, we should follow them out to at least a year. But what was interesting, if you look at the placebo versus the toxin here, you can continued improvement in modified Ashworth scale, almost going down by 2 points as you follow these patients out over the 3-month period, showing significant modification in tone. Unfortunately, we don't see what happens a year later. Do they actually have decreased contracture? But we do see that interacting earlier really has significant impact on how tone develops, as you see here in the last group with the big difference between the two. If you look at this slide, which is very busy, and I apologize, but they found changes in the most effective joints, they found changes in combined joints, they found changes in both wrist and elbow. They did quite a good job. They have goniometry measurements here as well, but they clearly showed that you can modify tone by early toxin injection, and that was more or less fixed when the study ended at 4 weeks. For the most part, toxin resolves or stops acting over 3 weeks, and I personally think it's good for around 8 to 10 weeks. But we're showing that we were able to modify tone in someone's arm. After the study was done, Ray Rosales went ahead and did a meta-analysis to see what else could be done and to see where we are. And there was actually 6 trials that are out there. They all showed that in general that you can change tone. They did not show that we were able to change function. But again, always looking at the short-term period. But they did show that pain was alleviated and to some degrees disability. But here's a meta-analysis of all those trials, and you can see that early treatment clearly has a significant impact when we want to look at tone of modified Ashworth scale. And I'm not saying that's the best scale, but that's what was used. But clearly a meta-analysis shows that early use, less than 4 to 6 weeks from an onset of stroke, is clearly beneficial. If we look at improvements in disability, if you look at overall disability, no significant benefit. If you look at group B and individual disability scores, then there was some benefit to that. Again, follow-ups for these studies are only around 3 to 4 months, and we really need to look at outcome at a year, would be my suggestion for creating a better trial. So if we look at this study here by Lim, Choi, and Lim, this is a really small study, but it really emphasizes a really interesting point. What happens if you take somebody who's, let's say, 2 months after their stroke, and you take somebody who's 5 years after their stroke, and we decide to inject them with toxin? Do they still both have the same response to therapy, even if they've had other therapies, the same adjunct therapies over a while? So not a big study here, and again, proof of concept. 15 patients with subacute stroke and 13 patients with chronic stroke. The definition of a subacute stroke in this Asian study was 76 days, and the chronic group was almost 4,000 days, so 4 to 5 years after their event. What's really interesting is that when they injected them with the exact same dose of toxin, they found that the subacute group responded a lot better. Both groups responded, but the subacute group responded a lot better than did the chronic group, suggesting that you have bigger bang for your buck early on, or perhaps we should be using higher dosages or more aggressive therapies in the chronic patients, because what this showed was that we got more range of motion, passive range of motion in the subacute group with a certain dose of toxin. So why is all of this important? Well, if we look at the last 4 trials I've been involved, or 1, 2, 3 trials I've been involved with, and we look at who we put in our clinical trials, we're looking at people who are getting toxin or aggressive spasticity treatment, I'll use that term, 4 to 8 years after their strokes. The mobility trial was a Canadian national observational study looking at how long do patients take to get into a spasticity clinic to receive toxin, and there's other treatments out there. That was 8 years. If we look at the best study looking at the cost effectiveness of botulinum toxin, we can see in Canada, Germany, or Sweden, the same population, 6 to 8 years for these people to get treated. And in the most recent study that's recently been published called the Reflex study, or here labeled as Allergan 116, this study had a mean time from event to treatment of 4 years. I think it's shameful that patients wait 4 to 8 years to receive their therapy. Mobility was done very early on and started in 2003 or 4. And the last study, the 116 study, is done more recently. It's nice to see we've cut that time in half, but we still have a lot of work to do because we're approaching patients later on. So I'm going to start to summarize shortly, but basically I want to finish with this last study. And this was another study done by Ray Rosales called the On-Time Study. And what he did in this study was again to look at what happens if we inject people with a neurotoxin really early on from their stroke, and let's say 2 to 4 weeks after their stroke, where they only have modified Ashworth scales of either greater than 2 early on, or they have an Ashworth of greater than 1, but they have some symptomatic spasticity such as pain, involuntary movements, impaired active or passive function. Sort of those minor patients we see every day in our stroke units that we sort of wait to see if they're going to get worse and don't necessarily intervene early on. That was the crux of this study. He had 42 patients, of which 28 were assigned to the toxin and 14 were given to the placebo group. They had one withdrawal from each group. And what was interesting is that 89% of the toxin patients versus 100% of the patients received concomitant non-drug therapies, and around 86% of the patients received physical therapy. Occupational therapy seemed to be less involved, with only 31% in this acute phase. And they all had a lot more therapy than we get here in Canada. They had almost 160 days of physiotherapy in this study. What's really interesting is let's look what happens if you got toxin into, and again, they were looking at the finger flexors, at the elbow flexors, and the wrist flexors, is what happens to these patients as you follow them out to 30 weeks. And if they looked at the criteria of either change in Ashworth to require re-injection of greater than 2, or to be greater than 1 and still have pain or not being able to participate in rehab. When they looked at 12 weeks, 71% of patients were still actively involved and did not require re-injection versus 35% in the placebo group. And then if we follow them out all the way to 30 weeks, around 40% of the injected group on a population of mild changes in tone still did not require any additional treatment. And we had modified either their pain, we had enabled them to participate in rehab versus only around 14%, and that should be 14.3% in the placebo group. So clearly, treating early on in that first 4-week period seems to influence the change of tone and enable patients to participate in their therapies. If we looked at change in Ashworth scales from each visit, you can clearly see in black that the group injected had the biggest impact, while the placebo group, despite the other therapies, really didn't show any change in their tone. So implying that we can intervene early on. They had no adverse events in this trial, and patients were able to participate much better. Unfortunately, again, they didn't put this trial out to a year to see what the incidence of contracture was, which to me is the most interesting aspect of it. But they did show that we can modify tone early on safely and effectively, and that we can help integrate more people into the rehab setting. So why should we assess post-stroke spasticity early? Early identification of spasticity risk factors allows for regular follow-up if we can figure out who's going to be at risk and make sure that we treat them at the proper time. Starting post-stroke rehabilitation early and maintaining its intensity is really key to minimizing long-term disability. That's been reinforced by Pam Duncan in the US. And if we can inject toxin or any therapy to modify spasticity early on, can we help maximize that intense early therapy? Not like the AVERT trial in the first 24 hours, but looking at its effect longer on. Most importantly is most neurological driven changes in muscle tone arise between 1 to 3 months post-stroke. Still, 1 in 10 people may develop spasticity afterwards, but intervening early on is really important. Waiting until spasticity is established before initiating treatment may impair rehabilitation and recovery, and I think it's foolish of us to wait till somebody gets really bad prior to being more aggressive. To me, it's almost like saying, let's wait till the cancer metastasizes before we initiate therapy. Why aren't we being more aggressive? Rehab therapies have been shown to be effective when applied within the first 3 months post-stroke and are likely to deliver enhanced benefit. We may decrease early onset muscle stiffness and achieve better long-term outcome and unmask potential for active movement. And how many times have we had somebody with some equinovarus foot that we've treated and then they were able to actively partake in rehab? Delaying treatment until spasticity is established may also be a negative and impair rehabilitation. We know that chronic spasticity leads to changes in muscle tone and leads to contracture. Early treatment prevents soft tissue shortening and may prevent contractures. In one study, and I'm not here to promote botulinum toxin use, I'm here to treat spasticity, but says that around half of the patients in a global survey at 1 year could have benefited from the therapy that wasn't offered to them. The implications of early treatment from the On Time study suggest that early botulinum toxin injections delay symptomatic spasticity development. Less people require interventions as we go along. Early treatment can modify disease progression before secondary local and biomechanical changes occur. We get less changes to muscle and tendon. And to me, spasticity is a negative neuroplasticity response that will progress over time and will really lead to functional impairment and disability to the patient, which is everything that rehab is trying to prevent. And finally, early intervention with botulinum toxin combined with adjunct therapies. I think we should throw every effective therapy at people can really maximize the impact of treatment and function and a muscle tone. And I thank you very much for your attention, and we'll turn everything back over to Patty.
Thank you very much, Dr. Wein. That was an excellent presentation. We greatly appreciate you sharing your knowledge. We do have several questions that have come in, and I encourage everybody watching to continue to submit your questions. So I will start giving them to you, Ted, and ask you to respond, please. So first of all, do you know of any studies that assess if there is any negative effects on muscle strength recovery when using early Botox?
Yeah, so that's an excellent question. I mean, the biggest fear we've always had is let's not inject early because we'll make people weaker and that will impair their rehabilitation. So I'm not aware of any study that's actually documented that early in weakening of muscle through neurotoxin has ever had any functional impairment. In the On Time study with Ray Rosales, the last study that I just presented, they had a whole section on safety and efficacy. And in the interest of time, I didn't go through all of that, but they actually show that patients actually had increased amount of active physiotherapy time and occupational therapy time. They did show changes in tone, but they did not show any significant weakening that impaired function. In the meta-analysis also done by Dr. Ray Rosales by those 6 patients, and the 6 studies, there was no report in any of those of functional weakening causing a negative effect. In theory, I fully understand it, but so far, and we have small numbers here in each of the studies, it has never been a significant a reported problem that we've seen. To date, at least in my practice here, I've tended to treat people earlier, and so far we have not had that occur. And if anything, it's the complete opposite, that we've increased the number of patients that have been able to go into active rehab as opposed to not being eligible for rehab from our acute stroke center.
Great, thanks very much. The next question, you've just touched on safety and mentioned safety. So there's a question about, is there a limit on how many injections a person can have, and is there sort of a maximum dose effect over a certain period of time?
Yeah, so another really good question, and it's very interesting because I just came back from 10 days in Australia 4 months ago, and our practice parameters are very different. There, they actually are limited to 4 injections just because that's all people will pay for in that country. But patients in Australia who have a stroke apparently get free rehab for the rest of their lives, at least 3 times a week. So a very impressive system. They're very active in splinting and bracing in conjunction with their toxin injection. So the answer to the question specifically per product monograph for all the toxins is that you can be injected every approximately 10 to 12 weeks. There is no limit on lifelong exposure to botulinum toxin, any of them. I'd point out the cerebral palsy kids get it throughout their childhood, and as they transfer to the adult clinics, they continue to get it. This product has been available since the late 1960s with a very good safety and efficacy profile. The second aspect of your question is probably the most challenging question, is what's the maximal dose that you can get? The product monographs depend on the product. Are very well stated, although we routinely treat above that. There was a recent study called the Tower study that showed that you could double the dose of the recommended product, at least with Xeomin, which is another form of botulinum toxin, with no adverse events. Most of the studies just look at upper or lower limb. As you're aware, we have people who have involvement of both. And for now, I'd say the majority of clinicians are quite comfortable going up to 800 units of Botox or Xeomin, using the trade names, and up to 1,500 units of Dysport, which is recently on the Canadian market as well. To date, we have not had very many side effects. You clearly can. There is some risk of systemic weakness with this, but we're still in our learning phase. In fact, I just published a study on equinovarus foot deformity for lower extremity botulinum toxin, where we used a dose of 400 units, and the national Canadian average was probably around 260 units that we used. And we showed that if you go to lower dosages, that you actually don't have a response, and that if your spasticity has been over 2 years, that you actually need a higher dose in order to maintain the same efficacy as an acute patient getting the same dose.
Great, thank you very much. Can you comment on what the potential underlying mechanisms are that might be contributing to splinting not being effective?
Yeah, so, well, the answer is no. The question is the splint actually causing enough change or stretch to whatever it's being used for to try to rearrange cortical plasticity? Most patients don't wear their splints properly, or the splints don't work. So I think more of a dynamic splint and some of these functional electrical stimulators may be a little bit better at that. But I think it's a complex question, and I think there's no therapy that really works great in isolation. And I don't want to say botulinum toxin is a panacea. I think Botox in conjunction with a splint or an ankle foot orthotic and physio is the only way that we're going to combat this disease. And I think it really needs to be done synchronously with all the other therapies available.
Great, thank you. Next question is, do you know of any initiatives being undertaken now to increase early access to botulinum therapy at a systems level? Is there anything ongoing or anything we could be doing?
Yeah, so absolutely. I think the rehab group as a whole needs to come out with new practice parameters and guidelines based on these newer studies and looking at the dose response rates. That we should be working as a community to A, raise spasticity awareness, B, establish corridors of care to people. 3, I would make this a practice parameter in the acute stroke unit as well as in the rehab unit as something that should be flagged, and then to have streamlined care from A to Z for these patients to be able to navigate the system.
Okay, here's a good one for you. So the person who submitted says, I agree that early treatment is optimal. Oftentimes, though, when we approach the medical team in the acute setting regarding treatment of spasticity, there's often resistance in doing so too early. Do you have suggestions on how to approach your colleagues to help get this in play?
Yeah, so this is so I've had the same challenge. So when at my institution, when I stated that spasticity occurred in the acute setting, my colleagues, my acute stroke colleagues, told me, no, we don't have it here, we don't see it, it's not present. And my argument was, you don't see it and it's not present because you don't really look for it. And so we actually systematically went through the patients one at a time, and all of a sudden we began developing that, hey, this is present there. I still don't think this is on everybody's radar screens. And that's why I was saying, and your previous question, Patty, is really to make it a performance outcome measure for a stroke unit to identify spasticity and make it people's responsibility. I mean, the data is there. This is a bad development. This is 4 times the cost of a stroke patient is quadrupled if you have spasticity. Number 2 is we're trying at the educational level to educate our residents who are more interested in this and be aware of it and more familiar with the therapy. I'd like to point out at the recent World Stroke Congress, as well as at our Canadian Stroke Congress, more and more rehab is taking a central front as to what needs to be done. So I think gently nudging them on, making them aware, maybe doing a little survey at any time in your stroke unit and say, you have spasticity in the following people, intervention is needed early on. I'm trying to change this at the level of the Canadian Stroke Consortium, and hopefully the Canadian Stroke Best Practices will look at this as a system driver for the future to bring awareness to this.
Thank you. Can you comment on the benefits of electrical muscle stimulation as an adjunct therapy for spasticity management?
Yeah, so I think functional electrical stimulators are good. They're costly, and the question is who is going to pay for them. We have several models out there. Binus comes to mind, who has a hand unit as well as a lower extremity unit. Interestingly, we don't have tons of studies that sort of combine therapy so often. There's a gentleman in the United States called John McGuire who advertises on television for what he calls shock and shoot therapy, of where you get shock from your electrical stimulator and then you're injected with your botulinum toxin at the same time. Unfortunately, we haven't had any clinical trials to suggest their need. These stimulators cost between $5,000 and $12,000 and require physiotherapist involvement. And most patients don't have the financial means. So I think absolutely a wave of the future. I think very helpful in select patients. Unfortunately, the question is cost. Who's going to pay for these? I was very fortunate to have a very wealthy donor leave me 3 Bionus hand units that he could purchase for himself, and then lost it, then found it, and bought another one 3 times. And so we use that on occasion in our stroke unit. Unfortunately, they're limb specific and side specific, so we can only use it for left-handed stroke patients because it doesn't fit on the right hand. But these are really good things, and I think we need to try to get more access to them, and I really envision it as a way for the future. Saying that, the question is, are these things better than really aggressive physiotherapy? Because let's face it, in our country, we're getting less and less rehab services, not more and more. And to that one aspect, I think that's another influencing factor of why we're seeing benefit easier with them. I'm not sure what a head-to-head trial would be with a active physiotherapist or the programs they have in Australia and functional electrostimulators, which most people can't afford.
Great, thank you. And on that note as well, one of our biggest challenges in treating spasticity in the rural populations is a lack of expertise. So do you have any suggestions on how we can improve access in rural areas? And another question that goes with that is, who can inject with these therapies? And does it have to be a physician, or can in a rural setting, a physio or other allied health care personnel be trained to do this?
Yeah, so I think anybody who has competency in identifying which muscles are affected and being able to localize those muscles either by ultrasound and EMG can do it. I'm not going to negate the abilities of anybody. For the most part, I would say it should be done with someone with competence in the field. In terms of access to outlying regions, it really is a problem. But I point out that I have several colleagues who go to outlying regions exactly for these reasons. I mean, the advantages of outlying regions is that there's usually one large center for a huge region. But I personally go to outlying regions. I know my colleagues Chris Boulios and Farouk Ismail in Toronto actually go to various parts outside of the Toronto area that require an airplane. Paul Winston in Victoria does outreach clinics in northern Vancouver. And I think it's really just a systems driver of liaising with the whatever rehab services evolve there, is to put together a group of individuals. And we're very willing to go. I'm willing to go to more places to bring this. I have patients who drive or are driven 10 to 12 hours to come and see me. Whether a family doctor can do it, I think it's a little bit of a challenge. I'm not sure EMG and ultrasound is so easy, and muscle identification. And I think the only negatives I see is, at least in a survey of my office, is 1/3 of my patients have been previously injected by someone else with lesser experience, I'll say. But I think the biggest failures of botulinum toxin are inaccurate muscle localization as well as wrong muscle selection. And as long as you can overcome that, then anybody can do it. But it takes some training, and I'm not sure it's a weekend course.
Okay, and then I think we'll wrap up with one final question here, and that's, are you aware of any other methods that might be in development to assess for spasticity? As you just said, it's important to be able to localize the right muscles. Are there other methods that might be in development other than the MAS? And their feeling was the MAS can be somewhat subjective. How do you comment to that?
Yeah, so I just hesitated because I just submitted a CIHR grant to this, so I'm not sure I really want to answer the question. So I will say that there are other scales out there. There's the Tardieu scale, which is favored by the French. There's the REPAS scale. I think one of the biggest bad things we've done in spasticity research is make the MAS our standard scale, and I agree that there's tons of deficiencies to it. Whether you want to do physiological recording of muscle, whether you want to do use any of these other scales, whether you actually want to do ultrasound of muscle and look at fibrosis and measure stretch of the muscle, are all alternatives. I will tell you that there is a movement amongst a lot of people to try to put together a new agent, a new scale to try to bring this to better fruition, to demonstrate benefit of this therapy, of any spasticity therapy, so that we can get more government support to fund it.
Great. And we're going to end it there. So I really want to thank you a huge amount, Dr. Wein, for your time and your excellent presentation. Thank you to everybody who joined us today. Just some reminders. First of all, we really encourage you to do the evaluation, and it'll be available. It'll be sent out to you, the link, and also to let us know what other topics you would like to have covered. Second of all, if you have other questions, you can submit them to strokebestpractices@heartandstroke.ca. And we will be sending out the YouTube link for you to share with your colleagues. And there will be certificates of participation for those who need them, and you can get those once you've completed the evaluation. Thank you a huge amount, Dr. Wein. And just a quick save the date to let everybody know, next year the Canadian Stroke Congress will be in Ottawa, October 3rd to 5th, so mark your calendars. We will be holding another Stroke Best Practice webinar in January, so watch for the schedules to come out soon. Thank you, everybody, and have a great rest of the day.